basically looking at several studies in a statistically highly significant format. And this quote I pulled off of there, that they demonstrated significant reductions in complications, in-hospital mortality, rates of unplanned reoperation, and surgical site infection with the use of checklists, and this is in human surgery, compared to pre-checklist rates. So again, if you have an effective and checklist and you use it, which is, you can develop all the checklists in the world, and then if you rush too much to use them, it's not going to help you. You can actually, it's been very well demonstrated on the human side. We don't have that strong of data on the veterinary side. This is an example, I know you can't read it, of a surgical safety checklist, but the thing to point out would be that there's basically 3 times that everyone in the room is supposed to check in. First, at the sign-in, and they're basically confirming the patient, the procedure, the anesthetic, the monitoring, any allergies, any certain risks, especially for airway or blood loss. Then right before the surgery starts, the actual skin incision, they want to make sure everyone in the room knows who everyone else is, what their role is, any anticipated critical events that might happen, and have they been given proper preoperative antibiotics and medication. And then at the end, before everyone leaves the OR, verbally confirming the procedure that was performed, the instrument sponge count, needle count, specimens, all that. So again, this is meant to be brief, it's meant to be usable, and it's really, everybody in the room is supposed to stop and do it. Now I realize that it may or may not apply to everything that we do, but I think the big picture is that if you want to perfect or at least improve the risk, reduce the risk of complications, that the use of a checklist that's applicable could be something to consider. So basically, there's this thick of a textbook of different kinds of complications you could talk about, every organ system, every body part, etc. And so what I wanted to try to just drill down on was a surgery that everybody in this room, if they do any small animal surgery, is probably familiar with, and that's spay and neuter. Okay, so I don't do a lot of spays and neuters here other than pyometras, or I do a lot more if I go on mission trips and that kind of thing. But I think it's something that we can all relate to no matter what our primary focus of practice or background is. There was a report that I read that was very recent, so it was published online in 2018 from the Royal College of Veterinary Surgeons in the United Kingdom. So this would be British, but I think it's probably very applicable to us. And they receive reports from private practices that through this data recording system, and basically included over 30,000 small animal patients across the United Kingdom in private practices that had spays and neuters over a period of time. So it's a very large cohort of patients. And when they looked at their definitions of complications, about 18% of cases had some sort of reported postoperative complications. So that's about 1 in 5 animals. Now again, we're not talking about death here, we're talking about something that they could define as a complication during the procedure or in the postoperative period until suture removal. About 9% of those animals, so about 1 in 10, required some additional treatment. Dogs had more complications than cats, and as you probably assume, spays had more complications than neuters. 1 out of 100 pets needed further surgery, and 1 out of 1,000 pets died. And so the reason to kind of drill down that litany of kind of summary of that fairly large report is just to say that if there's one surgery that we probably all would say, well, that's a routine surgery, it would probably be a spay or a neuter. But based on this kind of large amount of data, at least we would have to say even quote-unquote routine surgeries are, potential is fairly high for some level of complications. So what are the complications that can occur related to an ovarian hysterectomy? There's a lot of them, right? And I kind of broke them down into short-term and long-term. So the short-term might be bleeding, in the abdomen, vaginal bleeding, seroma, infection, dehiscence, anesthetic-related, abscess formation, suture reaction, trauma of the ureter, nephrectomy, and death. So those short-term would be things that might be seen in the first 2 weeks or less. Long-term complications that have been reported, retained ovaries, stuffed endometras, chronic draining tracts, granulomas, foreign bodies, obstipation, bowel obstruction, vaginal fistulas, pyelonephritis, urinary incontinence, and weight gain. So that's a lot of stuff, right? Not all these happen in every patient. Hopefully not all of them happen very often, but the reality is that certainly things can happen. Just a quick review of the female dog anatomy. So there's a lot of blood vessels, and there's some important structures with names there that we should know. How about neutered? Well, these are the most common complications that have been reported. Neuters, so swelling, bruising, scrotal hematoma, hemorrhage, incisional infection, dehiscence, abscess, chronic granulomas, urinary incontinence, urethral injuries, prostatectomy. This would be with cryptorchid neuters, which is a horrible complication. I've seen it 3 or 4 times. Not caused it, but seen it, and behavioral changes. So probably anyone who's done a fair number of neuters has eventually seen something like this the day after or a few days after surgery. And this is a scrotal hematoma with quite a bit of subcutaneous bruising there. And again, this can happen for a couple different reasons. Sometimes we talk about, is there a difference between bleeding and hemorrhage? I like to say bleeding you can see, but hemorrhage you can hear. Dr. Connect, who was at Auburn when I was there, who had been at Purdue at one point, was a great surgeon. He said if it wasn't for blood, everyone would be a surgeon. So this was my picture to demonstrate bleeding. This is an abdominal incision on a dog, and again, you can see some bruising in the subcutaneous area, so there could be several reasons for this bleeding post-op. And that's my best picture for hemorrhage. So if you get that, it's not a good day. Okay, so what causes post-surgical hemorrhage? Well, very often if it's bleeding in the abdomen following an abdominal procedure like a spay, it may be related to the technique. So ligatures that were too loose or improperly placed, knots that weren't tied properly, or suture that broke or slipped off of pedicle. Could be related to the patient, so sometimes there are dogs that have occult bleeding disorders. I've seen a patient before that was unknown to have ingested some rat poison a few days before it was supposed to be spayed. Sometimes that happens. So there are toxins and bleeding disorders, but those are pretty rare. Usually it's related to the technique or something that went wrong with the suturing of the pedicles. Extra-abdominal, so it could be from subcutaneous vessels. Usually those don't cause significant bleeding, but especially in dogs that may be in heat or pregnant, that's maybe more of a risk from the subcutaneous or skin incision. Realize that a lot of times when there's a hemoabdomen starting, sometimes they'll be oozing starting from the skin incision, so keep that in mind as well for abdominal procedures. Scrotal hematoma, we showed that can be either from subcutaneous vessels or can also be caused from improper tightness of the ligation on the spermatic cord. And then vaginal bleeding. There is a rare complication that I've seen 3 or 4 times. Dogs that were spayed a week or 2 ago have been doing absolutely fine, no problem. And all of a sudden started having vaginal bleeding without any abdominal bleeding. And we had the first case I saw here probably 15 years ago or more. That dog's hematocrit was 7 when it came in, and had been bleeding for several days, and they've been kind of trying to tap it off, and it seemed like it would stop, and then it would come back, and then we saw it. I think I've seen it 3 times. Every time what appears to have happened is everything was done properly internally, but one of the main uterine arteries somehow, and it didn't happen immediately, it happened several days to a week after the surgery, kind of eroded into the vaginal lumen, and the bleeding started just coming outside through the vagina without any abdominal hemorrhage. So really weird, but potentially fatal if not caught. So everyone's heard surgeons say all bleeding stops eventually, and the sign says whatever you do, give 100% unless you're donating blood. Okay, other complications. So this is a cat with an abdominal incision, probably from a spay, and you can just see a lot of inflammation there. And that could have been caused by patient trauma to its incision. It may have been caused by the clipping or prepping too vigorously. But again, inflammation in environments that are inflamed like that then have a higher risk for infection. We've all heard about the 5 cardinal signs of inflammation, which are across the bottom there. So heat, redness, swelling, pain, and loss of function. Remember that all wounds heal in phases. Obviously, those phases overlap. And don't worry so much about the time frames on this, because this is talking about specifically about certain open wound healing, but just the fact that we start with hemostasis, then inflammation, then proliferation or granulation, and then remodeling or maturation. So inflammation is a part of healing. It's normal to have inflammation, and during that inflammatory phase, the wound actually gets weaker before proliferation healing starts to occur by fibroplasia. Another one that we don't like to see is wound dehiscence, so when the edges of the wound separate instead of healing together. And this can be because of suture failure, so either the suture broke or was not placed properly in proper tissue layers. It could happen because of errors in judgment at the surgery table, which I mentioned there, like knot security or technique, too much tension. It could also occur because of patient factors, low albumin, infection in the tissue that's being sutured, endocrine disorders like diabetes or Cushingoid, or an overactive patient that causes some sort of self-trauma. I would also add to that would be radiation. So if you ever have the unfortunate experience of having to operate on an area that's been previously irradiated for cancer, that tissue does not heal like normal tissue. In fact, it often just falls apart no matter what you do. So don't do that if you can avoid it. If a wound dehisces, it almost always requires additional surgical treatment, and in some instances can even be potentially very serious or fatal. So, knot security is very important. Cartoon says a surgeon's knot should never give way. I have been in 2 operating situations where one of the surgeon's pants fell all the way to their ankles. Not mine. Just an example of wound dehiscence on a knee operation or a stifle. Again, this is probably related to infection and then secondary self-trauma by the patient to open up the upper half of that incision. Okay, so for abdominal surgery, like spays or any laparotomy, if there is a body wall hernia or dehiscence of the abdominal wall, that can occur either acutely in the first 2 weeks post-op, or it can sometimes happen chronically many weeks or even months or years later. Again, that may happen just in the subcutaneous space, which is better if you can identify that and get it repaired, or in more serious situations may result in evisceration, which could potentially be fatal or very serious. Chronic hernias usually happen either because of future endocrine problems or failure of proper fibroplasia, or sometimes secondary disease that causes a lot of abdominal distension. Some of those hernias may be small or asymptomatic, but others can end up with organ entrapment or severe swelling. So again, here's a picture of, I know this patient wasn't spayed, I don't know what surgery it had, but you can see that there's certainly some swelling and inflammation. It looks like some of those sutures have cut in and some of them are missing. Again, just looking at that, you don't know if that's a seroma, a hematoma, an abscess, or potentially a hernia that might have some abdominal content, so you'd have to do a little more investigation. But again, something that should be able to be treated without a lot of problems. Here's a cat that had been spayed a few days before, and again, now we have tissue protruding. It's probably some momentum. Again, thankfully caught at a phase where it could still be dealt with successfully, but you don't want to wait overnight on a case like this. Come in looking like this, which unfortunately sometimes happens through the emergency service. Obviously, not every one of these patients is going to make it. I've seen dogs come in walking on their intestines, and that's never good. But again, potential to be dealt with even with severe evisceration if you can get things cleaned up and sorted out there. Another complication that can happen following abdominal surgery would be adhesions. Basically, that's scar tissue where you shouldn't have scar tissue. Again, thankfully, in most of our small animal patients, post-abdominal surgery adhesions are pretty rare. Humans, it's a bigger problem. In horses, it's a bigger problem. But we do sometimes see it. It may be non-symptomatic, but it can certainly lead to sometimes abdominal pain or bowel obstruction, or even incarceration of bowels in certain areas in bowel necrosis. I would throw out just that final line. There is a condition, again, fairly rare, but we sometimes have seen called a sclerosing and encapsulating peritonitis. And if you ever seen one, you'll never forget it, because I mean that whole wad of intestines has got just one big scar thing around it. It's just, you can't even tell what's attached to what. Usually it's from previous peritonitis or previous abdominal procedure. Some of the dogs that I've seen with it probably had it for years, and then they got like a second foreign body or something, and we went in to try to remove it, and it's like, oh my gosh, it's a horror show. So that's one that is kind of a special condition that hopefully you won't have to deal with. Just a little laparoscopic picture looking kind of cranially and from the abdomen there, but you can see fibrous adhesions between the liver and the peritoneal surface of the abdominal wall. So just an example of adhesions. Like I said, those would probably not be symptomatic if you saw that, but if there were adhesions from bowel to bowel or bowel to other organs, sometimes that can be. All right, another one that hopefully you'll never create or have to deal with, but probably some of you have seen, it would be an iatrogenic foreign body. So basically an instrument or a sponge or something else left in a body cavity that shouldn't be there. And unfortunately, I've taken a number of those out in my career. I always say there's two types of surgeons: one who's going to leave a sponge, or one who has left a sponge, and one who's going to. As far as I know, after 27 years, I'm still in the one who's going to category, but that's where I want to retire someday. This happens not just in humans or in veterinary patients, but in human patients. Most recent report from the NIH said that about 1,500 human cases per year happen in the United States. And those would be sponges, needles, or instruments. And interestingly, the majority of those cases had a normal sponge count. So again, it goes to sort of the diligence of going through the motions. Even if you're counting sponges or counting instruments, most of those cases were reported to be normal, and yet obviously weren't. Here's an x-ray of a dog that you can see that little radiopaque squiggly line in there. So that's a gauze sponge that has a radiopaque marker embedded in it, so easy to diagnose. I know most of us probably don't use radiopaque markers because those sponges are more expensive, but it could help make that diagnosis more quickly if there was ever a doubt. Here's a picture of what we call a gaussipiboma, which is basically a walled-off sponge or gauze that was in the abdomen of a dog. And again, I've seen some of these where they were very chronic. Found one before on necropsy on a military dog that had a 6-year history of being diagnosed with pancreatitis and vomiting, and when it finally was euthanized and they did a necropsy, that was probably that sponge that had been in there for 7 years. This is a human one, just to show you that these happen to people. Hernia operation where someone left a little Wheatliner retractor in there. But I've taken a few Kellys and mosquito hemostats out of abdomens of dogs that shouldn't have been in there. So those are easy to see on an X-ray though. Another favorite saying of mine is that more things are missed by not looking than not knowing. I've had so many phone calls in my career where someone's like, we're in the middle of surgery and we just need you to tell us what to do right now. And I always want to say, hold the dog closer to the phone, I can't quite see it. But it is good to prepare. The bottom line there, if you can't read it, says, nurse, get on the internet and go to surgery.com. Scroll down and click on the "Are you totally lost?" icon. So again, it's probably good to be ready before you get into the middle of some of those, but there are times when it's nice to phone a friend. All right, so that's pretty much what I wanted to cover. I guess just a quick summary here is that complications go with the territory, no matter what type of practice you're in, and certainly in surgery, it's something that we have to be aware of and always diligent about. Anticipation of what complications and things can go wrong will help you minimize them. When complications do occur, I think one of the most important lessons to me is can you learn from them? And that, it requires then sometimes discussion and some reflection and retrospection. Preventing complications is a lot better than curing them, both for your own and again, it's always much more difficult to try to explain to an owner why that sponge got left in the abdomen, somewhere else. And so again, just, for all of us, it's better if we can prevent complications than have to deal with them. But I think one of the things that I would also say is that educating your clients, even for things as routine as spays and neuters, that complications can happen. These are some of the things that we're going to watch for, and that if it does happen, they're not totally shocked that you said this was just a no big deal kind of procedure. And then again, resist the urge to blame the client or the patient every time something goes wrong. There are times when it truly is 100% out of our control, but I think many times I see where I could have maybe made a different judgment to help prevent that based on even just the type of dog or the owner or the circumstance or how many little kids they had in the room with them at the time of the consult or whatever that might have helped prevent certain complications from happening. I always like to say that if you speak with a doctor, whether it's a human doctor or a veterinarian, and they tell you that they've never had any surgical complications, I would pack my bags and go somewhere else. Because either they're very inexperienced or they're lying, and you don't want that person in your surgery. Okay, my wrestling coach in high school loved to say, if you fail to prepare, you prepare to fail. And that's, I think, probably some good advice for all of us, no matter what we're doing. Dr. Wade Brinker, who's probably one of the founders of veterinary orthopedics, I wrote this quote down a number of years ago, reading something that he had written and kind of kept it stuck in as a notebook, bookmarker, but any technique will fail if not properly performed. In retrospect, very few fracture non-unions are free of error at the surgery table. So again, kind of the lesson there is you should be thinking at the time you're doing whatever procedure it is, what can go wrong and what can I put in place to prevent that. And one other way of saying that would be go big or go home when it comes to orthopedics, which was Ann Johnson's favorite saying during my residency. So that's all I had. I'm happy to throw the lights back on here maybe, and happy to open it up for any questions or discussion if anyone has any thoughts. Or you can just laugh. Has ever had any complications?
I've got a question.
Yes, sir.
Have you ever operated on a dog or a cat with a hydatid cyst?
I have not operated on a dog or cat with a hydatid cyst. You're talking like a Echinococcus or some sort of tapeworm? Yeah.
I think I got one.
Is it walled off or is it in the liver?
Well, it's in the liver.
Okay.
Cat lives on a cattle farm.
Okay.
And there are at least 40 cats on the property.
Interesting.
Lots of coyotes.
Yeah.
And when I ultrasound this thing, it looks like a honeycomb.
Yeah.
And it feels like the cat's got a sweet potato. Right.
Fairly large. Is it?
And it looks on the ultrasound, it looks like a cat's liver.
Okay.
Huge cyst in it.
Is it fairly asymptomatic?
No, it's having diarrhea.
Okay. So there is a condition, I've seen it, I've operated on a number of them, that could be what you're talking about. So he's asking about a cyst in the liver on a cat. It's called a hepatobiliary cyst. and they're can get quite large, like baseball size or bigger. They're often, they can be multifocal, but they're often solitary, and they kind of often hang off of the liver, and you can palpate them as a fairly substantial cranial abdominal mass. They're actually benign, although they look crazy, so I've heard of some cats being put down that probably could have been taken care of. The first one I ever took out was actually one of the barn cats at the University of Illinois. It was like they had down in the large animal clinic. They had some cats that kind of controlled the mice population, et cetera, down there. And one of the students was petting one of the older cats and palpated this thing and brought it up to the small animal surgery room, and we took it out. And I've seen a few of them here. So if it's just one and it's not like the whole liver, it may well, two things. One, it may not even be related to the diarrhea. And two is that it may well be surgically resectable and can be removed. And they are benign. They don't really know exactly why they're formed.
There's more than one little circle.
Yeah, but they're all connected to each other.
No.
They're separated. Okay. I have seen them where they're in multiple lobes, and usually we took out the big one or the biggest ones that were accessible because of this. They were like physically pushing on the stomach or whatever causing. And left the smaller ones. I had one cat that came back a year or two later. We took out another one that had slowly grown, but had been doing pretty well. So again, I don't know for sure that's what it is, but it would probably be more common than hydatid cysts. I mean, those are, as far as I know, very, very rare in small animals, especially in the hospital. I worked one summer between my second and third year of vet school for Kevin Gazakis, the parasitologist at Purdue. Actually almost went down that road professionally because I had a lot of interest in parasitology and public health. And my job was trapping rodents in central Indiana looking for the kind of coccus because they were trying to see if it had come into Indiana at that point. It hadn't been diagnosed, so I actually had 100 little steel box traps and a very old pickup truck that belonged to the pathology department. And my job was to go out on Monday morning and set a trap line and bait them for little rodents and mice and chipmunks, and then trap all week and take the weekend off and do that next week. So over the course of 8 weeks, I caught about 1,200 little critters, and we found all kinds of crazy parasites, but we never found the kind of coccus. Pretty cool, pretty fun job actually for me and that week. Have all these little mouse pelts. No, just kidding. Did not make it photo. Any other questions or comments? Thanks for coming tonight. There's certainly some food left and cookies and coffee, and if anyone wants a tour of the hospital, our administrative staff or technicians will be happy to do that, and there's also CE certificates for everyone who came. Have a great night.